Yes. No, the first one, the one. So the next. Yeah. I will write. Now, remember me. The last time you come here, you bring the concentrate for Japanese. It was nice. My mother asked me, just come away from home place. for the assisted reproductive technology, Japanese international standard. We do the names.
Cek, cek.
Indonesia dan
Before we proceed with our event, with due respect, I kindly request you to set your mobile phone into vibrate or silent mode as they may distract the event process. Thank you. Distinguished guests, ladies and gentlemen, my name is Lily and I will be the master of ceremony for this precious event today. First of all, on behalf of Morula IVF Jakarta, I would like to thank the Almighty for whose blessings we could attend this convivial gathering in good health and mind. I also would like to extend a very warm welcome to all our distinguished guests, honorable delegates, and participants for giving your honored presence on this amicable atmosphere to witness a ceremonial of the cooperation between Morula IVF Jakarta and Kyono ART Clinic Japan, and also a health talk entitled Women's Health and All About Infertility. It is an honor to me to introduce our main guest and Dr. Koichi Kyono, medical doctor from Kyono ART Clinic Japan. Please welcome. Nobuya Aono, an embryologist from Kyono ART Clinic Japan. A head nurse, Mrs. Eri Sakamoto. Please applause for her. Mrs. Tomomi Kuzuno, the secretary of Kyono ART Clinic Japan. Please welcome. Distinguished guests, ladies and gentlemen, the event proceedings are as follows. First session, opening remark from Dr. Agustin Yeli Tanda, a very experienced counselor in Morula IVF Jakarta. And then welcome speech by Dr. Ivan Rizal Sidi, the CEO of Morula IVF Jakarta, Morula IVF Indonesia, pardon. And then welcome speech from Professor Sugiharto, the chairman of Persitri Indonesia. The second session, the health talk, we have an incredible lineup of speakers. They are Dr. Koichi Kyono from Kyono ART Clinic Japan and Professor Arif Buyono from Morula IVF Jakarta. And then we'll be continued by panel discussion, which all will be hosted by
It is even with healthy condition. On the behalf of Morula team, I would like to say thank you for the attendance of our honorable guests. I also would like to say welcome to our honorable guest, Dr. Takeshi Baba from Japan Embassy. Welcome to Prof. Sugiharto, Head of Persitri Indonesian Fertility Organization. And as already introduced before by our MC, welcome to our expert speaker, Dr. Koichi Kyono, PhD, and his team from Japan ART Clinic. And welcome to the board member of Buddha Medic Company, Morula Doctors and College from Buddha Hospital. And for all the participants and our friend from media reporter. Thank you for your coming to this event. The problem of infertility has been such an issue for married couples who are longing for the presence of their offspring. Wrong information about infertility and lack of handling seems to make this issue is a problem without a solution. Morula Clinic has been established in 1997 by our founder, Dr. Salzini, together with reproductive medicine from University Adelaide, set up the clinic. Our first IVF baby born on June 8, 1998. So Morula will reach age of sweet 17 this year. Every year, the number of cycles increasing 30 to 50%. Till now, we run almost 100 per month in this year and have 3 branches in Depok, Surabaya, and Padang. The existence of Morula IVF as an infertility clinic aims to provide the education for those couples that they still have a hope of realizing their dreams. Supported by its updated technology and proven by more than 1,000 babies born in Morula since 17 years ago, made our clinic as the best and most critical in Indonesia. Along with the rapid advancement of IVF technology in Morula IVF and Morula IVF, and I repeat, along with the rapid advancement of IVF technology and Morula IVF, therefore we make cooperation with some of IVF clinics, both local and also international, as a referral clinic on IVF treatment. In accordance with the establishment of cooperation between Morula IVF Jakarta and Kyono ART in Japan on the development of IVF technology. Therefore, Morula IVF Jakarta organized this friendly health talk with Dr. Kyono, PhD. We expect that from this event, Morula IVF Jakarta is more widely known as a center of IVF program in Jakarta in particular and Indonesia in general, so that people don't have to go abroad to do IVF program. As I would like to share the purpose of health talk is to provide information about reproductive health issues for the participants in general and for the woman in particular, to provide the education for husband and wife and also public society about the problem of infertility and the solution to overcome them, to give a motivation for married couples throughout the pregnancy program. Finally, I do apologize for misspelling and mistaken in my speech. And also, I would like to say thank you very much for your nice attention.
Thank you, Dr. Alexi, for your inspiring words. Okay, we shall take this opportunity to call upon the CEO of Morula IVF Indonesia, Dr. Ivan Rizal Sidi, to deliver his welcome remarks.
Morning, Dr. Kyono and the team. Welcome to Indonesia, Pak Sugiharto. Terima kasih atas kehadiran. I'll be delivering my speech in 2 languages just to make the morning easier for everyone. This is a very good opportunity for us to have this wonderful event, to be able to share knowledge in between clinics, individuals, in between institutions, and I think we have enjoyed the the growth of infertility program in Indonesia overall. And we fully understand that Indonesian growth in the IVF program is highly determined on the quality of the individuals. And we understand that without learning from each other, we would only be good on our own. But when we learn to another, we will be good together and we become better together. And I think that's very important. In this day of age, I think Prof. Sugi will tell you more about how we can see where we're going in the future. Morula Indonesia has become part of global infertility proper management, and we have enjoyed so far a better technology, better laboratory, and better service to the patients. And to us, to see the increasing number of growth is only a very small parameter that we see, because what we want to see, how we can provide the best to our patients, to that what we can deliver. And to that, we can only continue to improve. At this moment, Morula Indonesia has already have 4 centers, and we are looking at expanding into a larger number of patients. We're expanding into a number of clinical services to be able to provide various ranges of infertility programs to be able to cater patients who are struggling with their childlessness issue. And I think we are leading in the right pathway and looking forward to be able to be acknowledged internationally, not only just nationally. As we have learned, 2 weeks ago, we signed a deal with the Chinese group where we have patients who will be coming to Jakarta to have treatment. We'll be about to sign an agreement with the Japanese group. We will be signing a standardization process with Asia Pacific Group. We have been invited to Africa to sign up an agreement to exchange training. So we are part of this worldwide community, and we have been acknowledged well. And I think we deserve to have a very, very good prospect ahead of us. So from what I can say to my last words would be that it is a very exciting moment for all of us to be able to stand where we are at the moment and having more collaborations with Dr. Kyono's group is going to be very fruitful, not only from clinical, from the nursing, embryology, and also from the administration viewpoint, because we can learn from each other how we can improve things by ongoing communication that we have done in the past few months already now. Just for the updates, we have been engaging a communication, teleconferences, visits from Japan to Jakarta, Jakarta to Japan, and we're having every 2 months teleconference discussing various of clinical and also other aspects of infertility treatment. And we are going to go to do this a lot more frequent, I hope. So I wish all what we are planning for today would be enjoyable as much as we can, and will be as fruitful as much as we could possibly have for the rest of the day. Thank you. Selamat pagi semuanya. Atas nama Morula Indonesia, saya mengucapkan terima kasih atas kehadiran pada pagi hari ini. Hari ini adalah hari yang sangat berbahagia yang bisa saya sampaikan bahwa kami telah berusaha untuk menjalin kerjasama dengan banyak tim, baik itu dari Indonesia, baik itu dengan regional, dengan Jepang. Kita baru tanda tangan dengan grup dari China 2 minggu lalu. Kita akan pergi ke Kenya, ke Afrika, ada kerjasama training, dan kita akan mendapatkan standarisasi akreditasi dari Asia Pasifik. Ini merupakan suatu bagian perkembangan yang kita harapkan bahwa dengan adanya pertumbuhan yang cepat ini, kita juga harus memperhatikan bahwa kita merupakan bagian yang diperhitungkan di dunia internasional. Nah, oleh karena itu, Disinilah kita perlu menunjukkan kepercayaan diri kita sebagai bangsa Indonesia bahwa kita bisa maju dalam mengembangkan pelayanan kedokteran, kesehatan, terutama dan pelayanan klinik IVF atau bayi tabung. Nah, oleh karena itu, harapan kami adalah dengan adanya pertumbuhan, bukan hanya melihat dari pertumbuhan dari jumlah pasien yang bisa kita treatment, karena saat ini kita sudah memberikan treatment hampir sekitar 1.000 lebih pasien setahun yang mengikuti program bayi tabung. Jumlah yang sudah sangat banyak sekali. Tetapi kita ingin lebih dari itu, karena kita inginkan upaya perbaikan pelayanan dari sisi kedokteran, perbaikan pelayanan dari sisi keperawatan, perbaikan pelayanan dari sisi lab, dan juga administrasi. Oleh karena ini, perlulah kita juga melihat bahwa tanpa kita belajar satu sama lain, rasanya kita akan menjadi pintar di negeri sendiri. Sudah saatnya kita pun juga belajar, dan mereka orang-orang dari luar negeri juga bisa belajar ke kita. Dan oleh karena inilah pertemuan ini diharapkan merupakan sesuatu yang bisa bermanfaat bagi kita semua, dan tentu harapan saya adalah kita bisa mendapatkan suatu hasil yang tentu menguntungkan untuk kita dan bermanfaat bagi pasien-pasien kita secara khususnya. Oleh karena itu saya ucapkan selamat bagi kita semua, dan mudah-mudahan kita bisa menikmati hari ini sampai selesai. Siang nanti sebagai tambahan kita ada kembali another Skype meeting again at 1 o'clock, and we'll be discussing about nursing issue and also a new project called PGS, which is basically a new project in IVF program that we will be engaging in with Kyono. Thank you very much. Very welcome this morning.
Thank you, Dr. Ivan, for your wonderful speech. And now I would like to invite Professor Sugiharto, the Chairman of Perfectly Indonesia. Ladies and gentlemen, Professor Sugiharto.
Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi, good morning, ladies and gentlemen. PhD Clinic Japan, welcome to Indonesia. Ya, pertama-tama saya ucapkan selamat kepada Guru Mula, karena kita menghadapi globalisasi ekonomi ASEAN. Mungkin ekonominya nanti akan diperluas dengan Jepang, Korea, India, China, dan Australia. Untuk pertama kali kita sekarang 2015 ini sudah menerima dokter asing, dan juga kita juga sudah bisa bekerja di tempat lain walaupun persyaratannya belum dipenuhi saat ini. Tetapi saya support kepada Guru yang sudah memulai untuk bekerjasama dengan luar negeri. Itu sangat penting oleh karena persamaan persepsi daripada keilmuan itu harus dicapai terlebih dahulu supaya kita bisa menerima dokter asing maupun luar negeri bisa menerima kita. Good morning, ladies and gentlemen. Group Clinic. The first time in Indonesia, IVF was born in 1987, and now we have 26 centers in Indonesia. Congratulations with the two group here. I support this collaboration. Thank you very much.
Thank you, Prof. Sugiharto, for your memorable remarks. Distinguished guests, ladies and gentlemen, it is the time we've been waiting for, a friendly health talk and panel discussion. Now I take immense pleasure to invite our notable moderator, Dr. Ari Adrianus Poli, to come forward. Please welcome. It is an honor to me to introduce to all of you about his brief resume. Dr. Ari Pauline is an obstetrics and gynecology consultant with subspecialty in assisted reproductive technology and Doctor of Minimal Access Laparoscopy Surgery. He is also Director of Indonesian Reproductive Science Institute, or IRSI, and the manager of Morula IUVF Clinic Jakarta. Dr. Ari, the time is yours.
Thank you, Lily. Good morning, all of you. Welcome, Professor Sugiarto, as Chairman of the committee, and welcome the guests from Japanese. How are you also? Thank you for coming today. Today we have talk about women infertility, and we are really lucky because we have two speakers. One speaker from Japan, Dr. Koichi Kyono, PhD. I invite you to come. And the second speaker is Professor Ari Budiono, PhD from Morula IVF Jakarta. Two speakers have many experience in background for the ART. The health talk is today is the purpose of health talk to celebrate the establishment of cooperation between Morula IVF Clinic Jakarta and ART Clinic Japan. Before we start, I introduce the first speaker, biography. Dr. Kyono received his medical doctor from Fukushima Medical College and his PhD in obstetric gynecology from Tohoku University in 1984. He was a member of Tohoku University team, which achieved the first IVF pregnancy and delivery in Japan in 1983. He is currently the president of Kyono ART Clinic. He has two clinics. The first clinic in Takanawa in Tokyo with 10,000 cycle years, and the second clinic in Sendai with 2,000 cycle years. Dr. Kyono is a member of Japan Association for Standardizing ART, member of Associated Society of Reproductive Medicine, American Society of Reproductive Medicine, and member European Society for Human Reproduction and Embryology. Without further ado, let's get started. Please, Dr. Kyono, for your question.
Thank you, kind introduction, Dr. Ari. Selamat pagi. It is a great pleasure to be here and talk ART in Japan. And I prepared the slide and 50 and a lot of photos. Please enjoy. And next slide, please. I experienced the great earthquake May, March 11 and 2011. Next slide, please. Next one. This is Ishinomaki Red Cross Africa. Next slide. And this slide shows Professor Edwards. He got Nobel Prize in 2010. Yes. And we made the t-shirt. I would like to introduce a Japanese institution of standardizing assisted reproductive technology aimed to improve the quality of ART for patient satisfaction, Japanese homogeneity, and service. The one, ISO 2001-2008, the certification. Two, inspection by doctor, ambulance, nurse, counselor, researchers, and patients. Three, improve together through friendly rivalry by encouraging each other. Next slide. We made dessert 2004. Next slide. This is the previous, next. This one, dessert inspection. This data is 2014. We have two clinics in Sendai and Tokyo, and OBU and Unified Home and Transfer, around 3,000 cycles and 1,200 cycle in Tokyo last year. This one shows the number of our staff: a medical doctor, OBGYN, urologist, neurologist, medical technologist, nurse, medical assistant, researchers, counselor, security. This is our buildings about Kyoto in Sendai. This slide shows the Kyoto Clinic Takanawa. I made a Tokyo clinic for risk management 2012. This slide shows the receptionist and the waiting room and the photo continue. Operation room, in operation room, the also operating room and ambulance transport and the micro district was performed. Brain edge procedure, one person, one brain edge. The counseling room and psychological counseling, genetic counseling. Laboratory room, we use the dry types in together. This one shows the post-op also. We detect with the spherical. We be careful to not enter the spherical. And the blood taking room, measure hormone levels. It takes 15 minutes to get the results. X-ray room for histosoluble brain. Recovery room. We have 9 beds. Powder room. Electric generator for power failure. It is very important. We experienced and great disaster. We had power failure, and so during the electric generator working, we have preserved the oocytes, spores, and embryos by identification method. Indication of ART and the total infertility, women and men, half and half. The definition of infertility, the couples cannot get a baby within 2 years even though through intercourse. Women cause tumor, ovarian, uterine, endometriosis, and unknown. Men, semen analysis, body density motility are few or zero, and spermatomotility high. The fee, the cost in Kyoto Alchemy and Kyoto Air Clinic Takanawa also. COS around we show the US dollars and IVF 3,000 and DC at 150 upgrade reservation and transfer respectively. I would like to show the total Japan's data in 2012. The total 300,000 cycles. FET cycles means the flow stone energy transfer. The AC cycles and orange color, and IV cycles blue color. And flow energy transfer cycles around 33%. This is the number of babies from ART. FET from energy transfer, babies from the energy transfer. 70%. Surprise. The only fresh oocytes and AC and other babies are around 10,000 babies. Most babies were born following from some energy transfer. This one shows the age, the pregnancy rate have increased according to the age of the age, and the miscarriage rate has increased. This one shows the optimal number of retrieved oocytes in 400,000 cycles in UK's data. According to this data, 15 oocytes is maximum birth rate. The severity of for PCOS patients. PCOS patients allow 7 to 10% of frequency of infertility patients. The definition and menstrual cycle is irregular, and we can detect the small androgen count in the ovary more than 12, and the average efficiency ratio is more than 1.0, and the testosterone levels is high. In our clinic strategy, IVF into maturation is the first choice. And in case of COS, we do GM outreach antennas protocol. And trigger is very important. We usually use GM outreach analysis in Japan, nasal spray. In Indonesia, subcutaneous injection, different. And our strategy all freeze and transfer on next cycle. Second, trigger geologic analysis at SGT 1,500 units on day 0, the same day of also retrieval, and day 5. And in case of pressure transfer, we would like to avoid the SCG injection as a trigger. This one shows the oocyte retrieval. We do the oocyte retrieval under the ultrasonography, transvaginal ultrasonography. And anesthesia is local anesthesia. We usually use local anesthesia. And if the patient hope, we do intravenous injection using global. This will show people vision and then critical. Time-lapse cinematography. In Tokyo, we have 2 endoscopes, and in Sendai, we have 6 real vision systems. This one shows the time-lapse exploration of morphokinetic parameters. And we can select the best embryos by TLC. And we can avoid the abnormal embryos by TLC. I'd like to show you the endoscope revolution and I'm sorry, it did not work. I would like to show the moving development of the embryos. This one shows the T0 is the also retrieval day and the insemination and IVF or ICSI. And next day, we can detect the 2 cells after 27 or 28 hours after insemination. And the next day, also with ACL and modular and graphics on day 5 to day 6. And I would like to show you the error transfer. More than 98% in our grade are single error transfer. We use a lot of kind of transfer system. I would like to show you the IPM, in vitro maturation, in the patient patients. And procedure, no nanotherapy. We check day 3 and day 10. And if we cannot detect the larger problems, we administer HCG, 10,000 unit HCG. And after 36 hours, we perform again. And we capture small follicles less than 12 millimeter. Immediate maturation for 24 to 28 hours. And after that, it is performed. And after 2 or 3 days, the image transfer is performed. And this merit is low cost and no OHSS. This is slide A is immature oocytes. And my side is the mature oocyte after 24 hours culture. I'm going to show you the endoscopic tuboplasty and government insurance coverage. This procedure's indication is obstruction, tumoral obstruction, especially in distance near the uterine side. Transvaginal, we insert the catheter and open the obstructed region. This slide shows micro-DC for endoscopy, non-obstructive endoscopy and obstructive endoscopy. We use this microscope, magnify 220 to 730. This slide shows testes. We open we can detect single tumors and thick and white, and we can detect displays. I'm going to show you the imaging intracytoplasmic morphologically cytosol injection. Magnify 300, magnify 6,600. We can detect the macules on the head. I would like to show you the fertility preservation. This protocol is our registration protocol for all sites. We use ethylene glycol DMSO. At present, also registration is the most common. In the clinic, more than 30 babies were born following oocyte coagulation. A female breast baby weighing 3,008 grams was born following liquefied bone oocytes in acute lymphoblastic leukemia (ALL) patient on July 21st, 2012. This is the paper. Libels from liquefied bone oocytes in the Philadelphia chromosome parity, acute lymphoid leukemia patients by restoring allogeneic bone marrow transplantation and up to magnitude 9.0 aspirated one. Conclusion. 1. GMH antagonist protocol is the most common in controlled balance stimulation. 2. GM agonist is recommended as a treatment to prevent OHSS. However, low-dose HCG $1.1 is necessary on day 0 and day 1 or routine support in case of fresh embryo transfer. 3. All embryos will be identified near future in Japan, especially day 5 to 6 85 on blasts transfer will be recommended. The exit immunity is effective in male factors. IVF is an useful technique in PCOS patients. Embryo selection is performed by Arab cinematography. In near future, PGS will be also used. 7. Paroscopic tuberoplasty in tumor factors and micro-tissue for unspoiled patients and positive confirmation for cancer patients are useful. Collaboration with modular IVF. 1. Exchange up-to-date information and techniques. 2. Training of doctors, nurses, and neurologists. 3. Generating mutual benefits. On a study linked to other police facilities, medical personnel may receive patients also. The 4. Pre and post care for patient result. Thank you for your attention.
ありがとうございます。Thank you for your presentation. For the next speaker is Professor Koichi PhD. He is a professor from Faculty of Veterinary Medicine Bogor. He is head of Department of Anatomy, Physiology, and Pharmacology. He graduated PhD from Yamaguchi University of Japan, and he has ART experience from the Kuramoto Clinic of Japan, and research fellow from the University of British Columbia, Vancouver, and research fellow from Michigan State University, USA. Professor is also embryology surgery director from Jakarta.
Thank you, Brother Ali. Assalamualaikum warahmatullahi wabarakatuh. So it's a good opportunity for us to explain what we already done in our team in Mola Jakarta, especially in Mola and Indonesia in general. So welcome also for people from the team. So today I want to talk about the embryo biotechnology update in human ART, especially what we already done in our life at Jakarta. As we know that the IVF program is the treatment how to get a blast embryo outside of the body. We collect the oocyte and we do the maturation sometimes and do fertilization and we put back the embryo to the womb. So this is what we are doing in the IVF program. The embryo biotechnology update, I want to talk this morning is concept of the extended culture blastocysts, frozen embryo transfer, assisted hatching, intracytoplasmic oncological selected sperm injection, spindle imaging system, also that we can also already explain. Individual culture using time-lapse incubator system and realization genetic screening. So these two will be soon be very quickly. So as we know, if we want to get the good and quality of embryo, it must be we prepare the good quality of the oocyte and good quality of the sperm. So this is the main procedure. If we want to get the good embryo, that we have to try how to get the good oocyte and select the good sperm, because for fertilization is only one sperm in it. So what we have done first, we starting our clinic, IVF clinic here in Jakarta. We used the UNITRIP for doing the embryo collection and embryo treatment, oocyte treatment, but now it's becoming old, so we moved to the laminar flow. This is we use the laminar flow with the single stereo microscope, but sometimes accident come, the disc will be falling down and it will put in this state. Now we using that the IMF working all is flat here, so for the accident for falling down the disc is now is avoiding. So more safety to work. So in this case also there are heating states. Previously, we used also the common incubator, CO2 incubator for culture. So once we put the, say, we have 4, 6 patients here. When we open the door, then temperature and gas will be decreasing. Now we move to the single and incubator. So each patient will be having one incubator is. So if patient A, we analyze the development of embryo, we not disturb another patient. And also, Dr. Kyono also telling about the time-lapse embryo monitoring system. Soon we will do this system also. So we never open the incubator for checking the embryo. So we just check into the monitor, and even we hope in the future the patient also can see how the embryo develop during culture in vitro. So we try to do that. The pregnancy rate after different number of embryo transfer, as the Dr. Kyono telling, in Japan they just only want to have one baby, single selected embryo transfer. So actually I have also experience in Japan for my postdoctoral last time. In Japan, they want to have a healthy baby, so they want only one baby each transfer. But in Indonesia, it's different culture. They still happy if we get 2 in the one treatment. By one get 2. Sometimes they think by one get 3, but yeah, me and Dr. Ivan and team, we teach the patient to have the healthy baby. So the question is, so what the excess number of the embryo? We have a system for the cryopreservation, so don't worry about the excess embryo. We can keep frozen and we can use later when we need it. So according to this data, nowadays we decreasing the number of embryo transfer. Previously we transferred 3, but now the Dr. Ivan's supervision we put maximum 2. Sometimes 3 it is just in case, but usually we put maximum 2 embryos because the pregnancy rate also is not different. So nowadays we do the 2 embryos per transfer. I told you that once we have more embryo access, then we can cryopreserve the embryo. Even sperm also. So in a modular team, we never do the ovum pickup when we don't have any sperm for the husband. So we do the PSA before the ovum pickup. So we cryo the sperm and we do the ovum pickup, because sometimes when we do the ovum pickup with the, I think it's high cost, sometimes we don't get any sperm. So it's also a problem. So we usually cryopreserve the sperm first and we do the ovum pickup. So for the cryopreservation, using the slow freezing, previously our survival rate only about 69, and now using the vitrification is about 93, and now coming to the 95%. So this procedure, I think that is also good enough. Also, as the Dr. Kyono team also there, using the same protocol, using the vitrification method. So I thought in this picture I want to show you. Sometimes the doctor asking about the good quality of the embryo, but they don't have any implantation. So in our laboratory, I mean in animal work, we saw that only 70% of the embryo will hatch after the blastocyst. So in Morula, even Morula Padang, Surabaya, and Margonda, this is as our standard operational procedure. When the embryo after vitrification, we always do the assisted aging. So we open the zona velocida, hoping that after they open the zona velocida, more easy the embryo will hatch from the zona velocida, and once the embryo hatch, it's easy to implant into the womb. No. Okay. So in this video, actually, we want to show that how we do the assisted hatching, and now we have also laser system. So without the without the needle, we do the assisted hatching. With the assisted hatching, the pregnancy rate nearly 50, and this is 5%. This is previous data. And some patients have a limitation of the sperm. So as the Dr. Kyono also asking about the fertility, not only women. Almost equal, half and half, also come from the husband. So in this case, we do the XT. So we, it's moving. The video is possible. Yeah. So actually, we select the sperm. You can try this. So actually, this is another procedure we are doing the XT. We select only the progressive motile of the sperm, and we do the immobilization. So the sperm will be immobile. We not select this kind of the sperm that moving is not straight, or this is also sperm. So we select the motor progressive sperm, and we aspirate the sperm into the needle. And only this sperm that we already select, we use as a sperm for fertilization. You can so you see that selected the sperm, we do directly place the sperm into the cytoplasm of the mature oocyte. So it's only one sperm. We place there, and we hope that after 20 hours of ICSI, we got the fertilization. See, this is the selected sperm. So we have to confirm that the membrane is broken, and only this sperm we put into the. So in this case, we answer that only select sperm we put into the cytoplasm of the mature oocyte. Yeah. So this is the standard procedure of our design. Yeah. So as Dr. Kyono also telling previously, when we see the motility of the sperm, moving the sperm by the magnification of that, by 400 times, we see the sperm is very small. But now we use the IMSI for getting there. So before use so actually, especially in Jakarta, the male factor is also high. So number of sperm is, the subnormal of the husband also high number. So if we cannot get the sperm from the ejaculate, we do the PESA, percutaneous epididymal sperm aspiration. we collect from this part, or if you cannot get the sperm here, we collect sperm from the testis, we call it testing. So will be done in this hospital. So we bring the sperm to our clinic and we do the cryo establishment first before opening up. So according to this data, whatever the male factor here, we can get the pregnancy rate using the ICSI. So if we have a problem with the male factor using this technology, it's possible to get the baby. Again, when we again, if we talk about the good quality of embryo, we should have a good quality of the oocyte and a good selecting of the sperm. So if we use 100 times, the sperm just like this figure. If the sperm is motil progressive, then we don't know how the possibility this sperm is good or not. By 200 and by 400, we use 400 times, we see this kind of the sperm. And once we use the IMSI procedure, 6,000, just like Dr. Kyono also explained, the sperm is very, variety of the sperm is very from the good to the rough, the embryo. So if we see with this procedure IMSI, we select only the good quality of the sperm, even they have a good motility progressive. So using the IMSI, intraplasmic morphologically selected sperm embryo, possible to examine each single spermatozoa. So not only by the progressive motility, but exactly the morphological. Provide all the best spermatozoa to be chosen for the IMSI. May exclude some genetically abnormal from the sperm, and it has been evaluated and seems to improve pregnancy. So we can see from this figure, if we see by transmission transmission electron microscope, if we got this kind of the sperm is very dark. So even this sperm is motility progressive like good, but inside is very dark. So this is will effect of the embryo quality. The indication of IMSI is patient with a previous failure of implantation. So the patient will be failure 1 time, 2 times, maybe the clinician will ask in the laboratory to do the IMSI. Patient with high level of DNA fragmentation. This is reported by the, I think, this is the IFF IMSI in patient with a previous failure. Actually, if we see in this group, in the first cycle, there is no difference of this pregnancy rate. If only 1 times failure, also is not different. But when the patient is more than 2 times failure, the pregnancy rate is significantly different. This is miscarriage also will be decreasing for the patient. So post-op also, Dr. Kyono already telling, not only the sperm, we also have the equipment, have the have the facility to check the quality of the oocyte. So we have to keep this chromosome safely. If we do IMSI in this position, it must be we got the degenerator of the embryo. So before the IMSI, we check the position of the chromosome, and we hope that we can get a good fertilization. In patient more than 30 years old, in the old patient, when this finger observed and not checked, the clinical pregnancy also is different and abortion also. So sometimes we can get a good embryo, but the implantation is a problem. Now we come into the pre-implantation genetic screening. So soon we will do this. if we see this kind of the embryo, sometimes we don't know this embryo is good or not. But morphologically, we tell yes, that is good because this is excellent embryo. But we don't know actually inside of the embryo. So we do the biopsy. You can do this. Or from the file. So in our lab now we have equipment for doing the biopsy. We have the laser microscope. So we open the zona pellucida and we aspirate, we biopsy one of these blastomeres to do the screening. So if this blastomere confirm this is the normal blastomere, the other one, the rest, it should be normal. So we also try to do this. Soon we will do. So this is if we use the day 3 embryo, it means in the 8 cell states, we only remove one blastomere and we continue culture of the rest of the blastomere. Okay. So you can next. This one. I suggest to the clinician or in the morula, we will do the okay. Same as before, we do in the day 5 embryo, the blastocyst. Because why we suggest in this state? Because blastocyst embryo, they have more than 100 cells. So if we biopsy about 10 cells, will not affect of the development of the embryo. So the question is, when we have the biopsy embryo, for waiting the result of the analysis, we can freeze the embryo until we get the result of the analysis. For the analysis of the biopsy the embryo, previously some clinic using the phase fluoro in situ hybridization. So using the special antibody, they can check this kind of the say this is a chromosome 18. They have diploid, chromosome 21 also 2 diploid, but the chromosome 13 this is tier 3. So this is excess. So this is abnormal on the chromosome 13. They also can see the X or Y of the this embryos. But nowadays for the PGT, for the FISH procedure, depend on the antibody what we use. Usually we just get maybe 4 or 5 chromosomes we can check. But by the microarray, we can explain all the chromosome from the chromosome number 1 to chromosome 23. So this chromosome 23 indicated the sex, mean male or female. So we can check here. We can tell this is the number of the chromosome 46, but 46 is not normal because chromosome number 15 is less and chromosome number 16 is more here. Here is XY, also this one. So this is a chromosome number 13 is more than normal, and here also. So if we get the, we want to have the healthy baby, of course. Then how to get this? If we suggestion of the Dr. Kyono that we have to apply the single embryo transfer. So if we do the single embryo transfer, we can cryopreserve the excess of the embryo, and we can use for the next baby, or if we feel we can re-transfer on the other one. So this is, I think, when the first I am working in Germany with Dr. Klamko, and now the lesson 2011. So of course this is affecting just more IVF. We got the visualization of the babies in the 1,000 babies on the RT, but this year is 17 years old already. So welcome to our website. If you want to see more, can and discuss with all of our staff. Thank you for your attention. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Arif, for the nice presentation. Okay, for the next session, we invite participants to any question, bahasa, or Arif or Dr. Kyono. Please, yeah.
Terima kasih, moderator. Saya bertanya, untuk usia sampai maksimum berapa seorang wanita dapat melahirkan secara alamiah tanpa ketergantungan peralatan-peralatan yang tadi disampaikan? Terima kasih.
For the next question.
I would like to ask to Mr. Kyono, in the issue patient, usually we get many outside, and you do, I think I get how many percent the best outside, and you transfer in the next cycle, you maintain the natural cycle.
Question? Yeah.
Assalamualaikum warahmatullahi wabarakatuh. Saya mau tanya, bisakah bayi tabung ini tetap dijalani walau misalnya ada kiska atau penebalan di rahim tanpa harus operasi, jadi bayi tabung ini tetap dijalani? Terima kasih.
In my experience, in the clinic and after spontaneous delivery, how old is around 45 or 46 years old.
Usia 45-46 tahun bisa normal in Japan. The next question for
our treatment in PCOS patients, and we can get the average of number of oocytes 20 to 0 oocytes, and we usually transfer the embryos in the same cycles. Same cycle means also retrieval cycle, and the fresh embryo transfer on day 3. Only one in day 3 for embryo. Fresh embryo. Yeah.
You can use the 20 all of the oocytes best?
Yes, we can get 20 individual oocytes.
Yeah.
So we in vitro culture 24 to 28 hours, and maturation rate is around 40%. So we can get mature oocytes about average 8 oocytes. So and the HC was performed, and so we can get day 3 good quality embryo 2 or 3. So we transfer one good quality embryos, and in possible we preserve the embryos on day 5 to day 6 last stage.
Jadi pada kasus PCO di Jepang biasanya dilakukan teknologi kecil, kemudian akan dikembangkan sampai dengan hari ketiga yang paling baik akan ditransfer, sedangkan sisanya akan dikembangkan sampai hari kelima ke dosis, kemudian dilakukan pembekuan individu, mungkin untuk bisa dipakai di next cycle. For the third question, for the we can do IV, I think there is 6 on the without operation. 6 over 6.
Endometriosis.
Endometriosis.
Cyst.
Depending on the ovarian cyst size, in Japan, the less than 5 cm, we do the IVF in the cycles. More than 5 cm, the ovarian and endometriosis, we recommend the operation before the IVF.
Jadi di Jepang kisah endometriosis atau tidak tergantung dari ukuran. Biasanya kalau ukuran di atas 5 cm memang melakukan operasi dulu untuk pengangkatan kisah. Tapi kalau besar dari kisah masih di bawah 5 cm, kita masih bisa konservatif untuk bisa dilakukan IVF. Tapi memang standar dari American College of Medicine bahwa kita memang standar untuk laparoskopi kistektomi itu kita melakukan ukuran dari 5 cm. Biasanya di bawah kita bisa tanpa perlu operasi kita bisa langsung ke IVF. Okay, any other question from you? In Dr. Takesi, Bapak Takesi, sorry.
Saya tanya ke Prof. Kyono, waktu itu ada teknisi dari Australia mengenai teknik PhD. Mungkin Prof. Kyono sudah bisa menerangkan sampai di mana apa yang sudah dilakukan di Australia. And I would like to ask you more questions to Dr. Kyono. You said that you have 20 oocytes, but you just only 3 embryos. What problem with another embryo, another 17? Do you think it's an abnormality or something like that of abnormality of the oocyte?
Yes, and I answered average number of 20 natural oocytes. And we can utilize only 3 day-free embryos. And another 17 embryos. And we guess they are unemployed or degeneration embryos, abnormal embryos, I guess.
Terima kasih Prof. We already signed up with the team from the Australia or the PGS, and now what we already done in our clinic is how to biopsy embryos. We already have the laser, we have method, and once 2 of our staff will be sending to workshop in Barcelona next week to improve, to optimize the biopsy. And we try also to send the biopsy embryo to the Australia, and we will do also here. So we do the both strategy. So we will establish our system all here during this time because the patient demand also is very high, we try to ship the sample to the Australia just to see what we done here is working there. So this is our progress. Then soon we will try ourselves here. So up to biopsy, we confirm that we have already the technology. And for the analysis of the PGS, the micro PCR and or hybridization up to the microarray, we will try and we use alternative. One we send to the Australia, and the second we do in our own clinic. So maybe by next week we can see our facility in our Jakarta.
What kind of patient you do have PGS? You PGS more than 75?
Yeah, I think this is also, of course, the clinician will be explain also. Yeah, usually for the old patient, and then the individual patient, sometimes we get a good quality of embryo, but they fail for implantation. So we're thinking maybe the morphology is good, but the chromosome something happened there. So maybe Dr. Ivan or Dr. Ali can give more information about that. But once our SOP, if the patient is old patient and very small number on the outside, the embryo, and more than times of failure of the previous IVF, then we suggest to go to the GS. Yeah.
Maybe I can add.
Yeah.
Just to add, in regards to the issue of PGS, currently we are already completed the pathway of process where we're able to do a proper biopsy, and we, as the end objective, are hoping that we would be able to do everything in-house in Jakarta. And the whole instrument, the microarray PCR, will be arriving in the next couple of weeks or so. But for the time being, to make sure, because genetic outcome is very, very critical and also very important, that will provide the best result. We want to have two comparisons, one that we do locally and ones that we send overseas to Australia. So we have been able to send samples to Australia. Now what we like to do is to compare samples that we do here is comparable to the samples that's sent to Australia. But what I'm interested in, the point of why we're doing this, I think your presentation of Arif is really quite important. That I really would like to see, even with day 3 embryos, majority of your embryos are day 3 in Dr. Kyono's clinic, but only transfer majority one embryo at a time. Meaning, you have a control to be able to look after your pregnancy outcome, not the pregnancy as in pregnancy test positive, but having a healthy baby in the end. Because having 2 embryos, 2 babies, would increase your risk of premature, would increase the risk of pregnancy complication, and so on and so on. So I think I really am quite glad that you pointed out in this message that one embryo and one healthy baby is really quite important. And how we're going to achieve that, I think PGS is one of them.
Okay, there's because of limited time, I think we close for the talk today. And thank you very much for Professor Ali, Morula, and Dr. Kyono from Japan. And thank you very much for your attention, and maybe we can meet in the next seminar, the next talk.
Thank you.
Thank you very much once again, Dr. Koichi Kyono, Professor Arif Budiono, and Dr. Ali Adrianus Pauling for your wonderful job in preparing our today's discussion. Ladies and gentlemen, please give them a round of applause. Distinguished guests, ladies and gentlemen, those conclude the proceedings for this event. May this help of beneficial for all of us with another new knowledge. Our Lord's grace is everlasting, to lead on when shadows fall, from the moment we were born and beyond, forever answering when you call. When there is a will, there is a way. Morula IVF Jakarta, when dreams come true. Thank you all for coming, and see you again in other greater opportunities. Arigato, terima kasih, farewell, sayonara, sampai jumpa. And for Dr. Kyono's team and Dr. Ivan's team, and Professor Sudi are allowed to the board meeting room for the signing ceremony of agreement.
Apa dokter? Ini. Oh iya.